don't throw away the cast, otherwise conservative management of pediatric forearm fractures. Just yesterday night, I was discussing with Dr. Kailash. He was showing me this case. See, this is an 11-year-old boy, fall on an outstretched hand. He sustained a both bone distal forearm fracture. So the initial close reduction X-ray was this. Now, the treating surgeon, he didn't attend the Preethi trauma update course. So what he thought, that this is completely translated, so it is 100% displacement, you should go and operate. So what he did is, he did some, I think, open reduction and K-wire fixation. And what do you think will happen now? Will it heal? It went for non-union, it went for deformity. So as primals are properly just mentioned previously, the only way a distal fracture is going to go for non-union is when you intervene. Actually, there are papers which show that such a deformity can be left untreated also. It will remodel very well. I want you to all go and read this article. This is a well-written article on the non-operative management of pediatric upper extremity fractures in the same topic, don't throw away with the cast, by Professor K.E. Wilkins. So we always say children are not small adults. See, in adults, we think the forearm is a joint, you have to always fix the forearm fractures. But in children, more than 80% of these fractures can be managed conservatively because they have excellent remodeling potential. Also, these children's bone are more porous and soft. So the adult bone will fail only in tension. The children's bone will fail both in tension as well as in compression. So there are special fracture types. So before that, we should know the muscles forces which are acting in various parts of the forearm. The proximal third is the supinator and biceps territory. The middle third is the pronator teres territory, and distal third is pronator quadratus territory. This is very important. The fracture types of children, first is the torus or buckling fracture, second is the plastic deformation, third is green stick, and finally the complete fracture as seen in adults. A torus or buckle is nothing but a periosteal buckling due to compression. They even say that there is no need to cast them, just give a splint and give analgesics and send them off. Within 3 weeks they will be normal. And when the strain increases, the next stage is the plastic deformation. This is a special fracture which we see only in children. See, there is no fracture line visible, but the entire bone is deformed, it's curved. This occurs because of multiple microfractures throughout the bone. Should you fix the plastic deformation? There are certain criteria. If the child is more than 6 years age, if there is more than 10-degree angulation with visible deformity, resection of pronosupination, in these conditions, you have to intervene. So though it seems innocuous, you actually need anesthesia to reduce this, because you have to give sustained pressure for 2 to 4 minutes. Around 100 to 150% of the body weight of the child has to be applied over a fulcrum. So this needs anesthesia, and once you reduce this, you will get put in a cast. The second stage, as the strain increases on the bone, now the tension side fails, the compression side is still intact. This results in the green stick fracture. If both the bones are fractured in the same level, there is only a bending violence, there is no rotational violence. But if both the bones are fractured in different level, then you should always think there is a rotational force involved. Now, depending on the apex of the deformity, you can identify which sort of force. If the apex is dorsal, it is a pronation injury. If the apex is volar, it is a supination injury. Now, how to treat this? Actually, Evans in 1951, he described this in JVGS. So, if the apex is volar, the supination injury, you will just pronate to reduce. If the apex is dorsal, you supinate to reduce. But again, volar, pronation, we may get confused. So, Noonan and Price, in their article in Journal of American Academy of Orthopaedic Surgeons, in 1998, they told about a simple method. You just rotate the palm towards the apex of the deformity, and you will correct this. Now, typically in our UG and PG, we were taught that if it is a green stick fracture, you have to complete the fracture. Here I am telling you just derotate it. So, see, the advantage and disadvantages are, in osteoclasis, if you do, you are completing the fracture, there is a wide surface area of the fracture, exuberant callus will be formed, refracture rate is less. But the rate of displacement, recurrence of the deformity is around 25% when you compare with just 10% in the derotation. So nowadays we just derotate. How to identify whether there is a mall rotation after putting a cast for green stick fracture? There is something called as radius crossover sign, described by Price again in 2012 JPO. When the forearm is in supination, there is no crossover. When the forearm is in pronation, the crossover is proximal. When the forearm is neutral, the crossover is distal. Now let us take a case example. What do you think? Whether this case is properly reduced or not? Now, simply what you have to do, split it into proximal and distal parts. When you see the proximal part, it looks as though it is in pronation. The distal part looks as though it is in neutral. It means the rotationally it is small aligned. Coming to the complete fracture, the treatment plan of the complete fracture depends on various factors like age of the child, time since injury, displacement level, stability and type. Now, Price has described this acceptability criteria depending on the age, first less than 9 years or more than 9 years. So, if it is less than 9 years, more amount of angulation, 15 degrees can be accepted, malrotation up to 45 degrees can be accepted. If the child is less than 9 years, usually 10 degree angulation accepted, except in distal most fractures where you can accept a bit more angulation, and rotation up to 30 degrees can be accepted. But 100% translation is acceptable, bayoneting is acceptable, provided that the overlap, the shortening is less than 1 centimeter. What is the effect of angulation in the arc of motion? Actually, the radius rotates around the ulna in an arc. So, when there is an angulation of around 20 degrees, there will be more than 30% loss of rotation arc. Now, we'll go for reduction technique. If there is a severe edema, kindly wait. Put a slab, elevate the arm, wait for 40 to 70 hours till the edema subside. Then again under anesthesia, you have to exaggerate the deformity and walk it along the distal fragment, and then we will lock it and you can put the cast. Casting technique is the most important in the entire conservative management. See, you have to apply proper padding. You should not apply over padding or under padding. If there is over padding, the elbow is not even placed properly at 90 degree, then the cast will become bulky and the so-called banana cast. You have to apply a very snug fitting cast, and also you have to give proper molding. The 3-point molding as well as the intraosseous molding. And as ulnar border has to be maintained in a straight way. You can use either a clipboard or you can use a ruler to maintain the ulnar border. And if there is an edema, you can bypass the cast, and after 3 days you can complete the cast. There is something called as cast index. This tells you whether your cast is good or not. If your cast index is nothing but the inner cast diameter in the lateral view divided by the AP view, it should be less than 0.7. Now, sometimes in a very young child, less than 2 years with a short stubby forearm, then you will not be able to put the cast in flexion because it will slip, the forearm will slip within the cast. In such cases, you can do a extension casting with proper supracondylar molding. And also, you can include the thumb in all the casts because after some time the edema is going to set in and the thumb will going to get compressed by the edge of the POP. So, it is not for stability, it is for preventing the pressure, so you can include the thumb in the cast. How to assess the reduction in complete fracture? You have to see whether the radial bow is maintained. As I told, 1 centimeter shortening, 100% translation is acceptable. Angulation as per the Price criteria. Rotational malalignment is poorly tolerated. How to check the malrotation? Simple. The radial styloid and the bicipital tuberosity should be around 160-180 degrees opposite to each other. In full supination, the bicipital tuberosity will be medial. And then in the neutral position, it goes posterior. And then in the pronation, it comes lateral. So you have to follow for compartment syndrome. The cast edema subsides. In 3rd day, you take an X-ray and complete the cast. Weekly, you have to take check X-ray for first 3 weeks because most of the times within the first 3 weeks, due to the subsidence of edema or some other reasons, there may be re-angulation. If something happens, you can even re-manipulate and recast. In 20 to 40% cases, it is necessary. And average, you have to immobilize them for 6 weeks. Finally, if there is a mild deformity in a uniplanar apex is there, less than 5 degrees can be easily corrected by so-called cast wedging. What you have to do, you have to open a wedge closer to the apex of the deformity, and this is a simple non-invasive OP procedure you can do. So finally, take home message, close reduction and casting is the gold standard even now for children's fracture, except few indications which next primal sir will be telling, and reduction should be done under anesthesia. You have to derotate the green stick fracture. Always keep in mind about the acceptability criteria and always check for the proper reduction in the post-casting X-ray. Good casting technique is must and follow-up X-rays should be done. Thank you.